Scenario 1. Digestive system, gastroenterology. Gastric ulcer with massive upper gastrointestinal bleeding. A 58-year-old female was rushed to the emergency department following 3 bouts of hematemesis and a single bout of melania. On examination, she was tachycardic and hypertensive at 121 beats per minute and 90/50 mmHg, respectively. She manifests pallor with no uterus. She is aerobic and non-methanic but reports intermittent umbilical tenderness. Medication history review occasionally. Intake of a non-steroid anti-inflammatory drug, nospamin 250 mg for arthritis management. On admission, her complete blood count revealed a hemoglobin level of 5.1 g/dL, hemocratic of 32%, prolonged prothrombin time and a positive guaic test. All other laboratory studies were within normal limits. Based on clinical presentation, intravenous fluid were administered and 3 bags of packed red blood cells were transfused. A gastroenterologist was consulted and an upper gastrointestinal endoscopy was performed, which revealed a 1 centimeter hemorrhagic gastric ulcer. The bleeding ulcer was contourized and bypassed were taken for Helicobacter pylori, the result of which are negative. Prompt pump inhibitor were stated and she was discharged after 2 days in stable condition. Scenario 2. Diabetics subsequent diagnosis. Uncontrolled non-insulin dependent diabetic mellitus. A 58-year-old female with non-insulin dependent diabetic mellitus was seen in her primary care provider's office with report of diminishing sensation in both feet and occasional blurry vision. Declined admits to problem adhering to her prescribed dietary and medication remain. She does not exercise regularly, taking her medication only when she reminded, and does not watch her diet. She denied dysmenorrhea, polyuria, polydysmenorrhea, polyguria, and dyspolyrisis. The client had a history of non-insulin dependent diabetic mellitus for 15 years and dyspolydria and hypertension for 8 years. She had laser photocoagulation for retinopathy in the past year. She is on metformin and glipizide for controlling of hypoglycemia, hydrocolizide and April and antihypertensive and atrovatan for hyperlipidemia. Upon examination, her blood pressure is 185/98 mmHg. Fast blood glucose is 265 mg deciliter. Hemoglobin ACI is 9%. Serum blood urea nitrogen and creatinine at 53 gml deciliter and 4.4 mg deciliter respectively. Urinal analysis and 24-hour urine collection uncovered trace protein and urinary albumin extension rate of 255 mg day, leading to diagnosis of microbulimia. Never conduction study and electrographer confirmed diabetic neuropathy, decreased fission acuity, and new extensive reticular vascular growth were revealed through an ophthalmologic exam. Based on the client's typical presentations, the final medical impression and diagnosis is uncontrolled insulin-dependent diabetic mellitus, complete by hypertension, dyslipidemia, neuropathy, retinopathy, and microbulimia.